Good morning, good afternoon, and thank you for joining us for today's VIA VitaFlow in association with you live webinar. My name is Michelle Harrington. I am a registered dietitian on the medical and scientific affairs team with VitaFlow North America. We're excited to bring you today's educational activity. Today's topic is gut microbiome and the role of Synbiotics in pediatric chronic kidney disease. Support for this presentation was provided by VitaFlow North America, a Nestle Health Science company. The views expressed herein are those of the presenter and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented. It is for educational purposes only and is not intended as a substitute for medical advice. Please note, questions will be addressed following the presentation. However, you are welcome to submit text questions into the Q&A pane at any time during the program. I'm excited to see we already have a question. Questions relating to VitaFlow product, however, will not be addressed during this webinar. Feel free to contact your VitaFlow strategic account manager for product information following the program. You can access a PDF of the slides in the link on the left-hand column. You will receive 1.25 CPE credits after listening to this program and after completing a short knowledge assessment that is required by CDR. This will launch within the program at about 2 p.m., so please look for it. Now I have the pleasure of introducing today's speaker. Christina Nelms is a registered dietitian with over 20 years of experience in pediatrics, primarily working with renal patients. She's held several clinical positions, most notably at Children's Mercy Hospital and Clinics in Kansas City, where she currently works. Christina has been involved with speaking and educating at local, regional, national, and international professional renal meetings, as well as authoring 3 book chapters and other publications. She is also a member of the International Pediatric Renal Nutrition Task Force, whose main goal is formulating clinical practice recommendations to enable best practice in the nutritional management of children with CKD. She has been instrumental in setting up and leading the Pediatric Renal Dietitians of North America, also known as PRONA, which is the first professional practice group aimed at serving as the leading source of pediatric renal nutrition expertise in order to improve patient outcomes, promote community and networking amongst pediatric renal dietitians. At this time, I would like to hand it over to Christina.
Thanks so much, Michelle, for the kind introduction. I am excited to talk with everybody today about the gut microbiome. I was just telling Michelle before our event today, this is one of my favorite topics and webinars. Actually, I gave a talk on this topic first in 2012, and the amount of information on the subject of the gut microbiome and CKD has just exploded in that time. So I've spoken about this subject at different events. I've done this webinar before and of course updated it, but spoke at CKD meetings, transplant meetings, etc. So today we're going to describe the role of the gut in kidney disease. We're going to discuss some challenges and complexities related to the gut microbiome in CKD, and then we're going to review the evidence available for probiotics, prebiotics, synbiotics in CKD and other conditions. So I wanted to start with just a quick overview of the microbiome. I know that this is a hot topic, so most of you may have some background knowledge, so I'm going to keep this brief. But in short, we know that the gut microbiome was really first treated about 2,000 years ago. They didn't know that's what they were doing, but soured milks in nomadic groups were known to show health benefits or treat different things. So that is really our first understanding of use of probiotic or prebiotic type foods. The microbiota itself, though, was actually first discovered in 1908 by scientists, recognizing that this tube we had going through our body was more than just a tube, that it had a diverse and active and live bacterial composition. And another just interesting fact is Bulgaria, where kefir and certain yogurts were first really originated. Bulgarians were known for their longevity, which is largely promoted to the fact that they had a diet rich in pre and probiotics. So we're just going to start with some definitions, and actually my definitions have increased. Probiotics has been a buzzword for a long time, which we know are live microorganisms that can confer a health benefit on the host. And then next we really came into the literature discussion about prebiotics, which are foods and non-digestible ingredients in foods that provide benefit to the host, that actually really create the beneficial bacteria. So they are not bacteria themselves, but they create that bacteria. And oftentimes these are found in fiber or fermented foods. Synbiotics is a term recognizing that many of these things are synergistic, that some of the things that we consume have both components, and that it really works together. And the new term that I've actually added to this webinar is postbiotics, and that is non-live components that can be given to the gut. The key that still provide beneficial effects, and the key here is that they're not living, which can have some different implications potentially for safety. And a good example of these would be short chain fatty acids, and whether we can administer these in the gut. But they still provide the health benefits. So let's talk a little bit about the gut microbiome in development. So one thing that we know is that a lot of our gut microbiome is determined through the birth and the first year of life. So many things, such as whether you were born via C-section or vaginal birth, comes into play, which is why vaginal births are often encouraged, if at all possible. Breastfeeding, as I'm sure as dietitians and healthcare providers, is well known that breastfeeding or breast milk really enhances the gut microbiota. But everything from mother's gestational age, so her primary gut microbiome, sanitation, antibiotic exposure in the first year of life, when we introduce solids, what type of solids are introduced. There's a lot of change that happens in that first year of life. The microbiome does continue to change into childhood, but it starts to stabilize. Then we see the next biggest changes in the gut microbiota in pre-adolescence and adolescence, as we're seeing the hormonal impacts of puberty. And then largely it stabilizes in those adult years. Now, that's not to say that it isn't a truly living organism. Our gut in and of itself is a living organism. And we do see changes, particularly if we rapidly change our diet, or if we have some sort of insult to that gut microbiome. But in the natural course of life, the gut microbiota largely stabilizes in those adult years. Of note, it does typically change in older adulthood. We see in the elderly a reduction in the abundance and diversity of pathogens. We know that that's preventable, though, that you can alter your diet and potentially improve your gut microbiome even into adulthood or older adulthood. We also know that there's a huge role with the nervous system, and so mood and stress really affects how our microbiome reacts. Okay, so now we are going to turn to chronic disease and the role of nutrition in the gut microbiome. So what we know about nutrition's role in the gut microbiome is that fiber is a huge player. Fiber promotes the development of short-chain fatty acids, or SCFAs. And these play a positive role in preventions of cancer, inflammation, immune function, many things. And in fact, we know that your mood is affected by your gut microbiome and vice versa. So when we have higher serotonin levels, we tend to have a healthier gut microbiome. It creates an environment favorable to those beneficial bacteria. And when your gut has more negative microbiota, it can also affect mood, depression, mental health, things like that. Some other considerations. We know that what is considered the Western diet, high in meat, processed food, sugar, saturated fats, low in fruits and vegetables, and our beneficial fats, is associated with dysbiosis, or altered or undesirable gut microbiota. We know that people who struggle with obesity have more pro-inflammatory species. We know that if you change your diet, if you switch to a higher fiber, lower calorie diet, that can promote beneficial bacteria production in your gut. We know that there's concerns with many of the fad diets we're seeing with Atkins or keto, that reduces our gut microbiota diversity. We know that stress, again, that mental health picture really plays into creating more of a negative microbiota. We see gut diversity changes evident really across populations and across. Now, we do have different gut microbiota in different parts of the world and different ethnicities, but we do know that these diet changes are associated with negative or positive changes across the spectrum of ethnicity and race and whatnot. That when we have a diet lower in fiber, for example, whether you're Asian or Caucasian, we're going to see similar changes for the negative. This also means that because there is a diversity by ethnicity, where you live, all sorts of factors, starting from birth, that there is a potential for microbiomics, which is the study of the gut. And there are places that you can spend $100, send in a sample of your stool, and they will let you know about your gut microbiota. Now, is this legit for treatment? We don't really know. This is used primarily in research, but whether we can do this just sort of a la carte on our own is somewhat unknown, but it is a potential also for the medical community, where we draw blood to determine what your serum lab values are. Are we going to be starting to see more of microbiomic analysis of the GI tract to determine what we need to alter or change to improve the risk for certain conditions? So now I want to talk more about pediatrics specifically. So this is a table from 2016, and I tried actually to find a more updated table without much luck. So there is a lot of new research in many of these conditions or other conditions that have come to light, but I wanted to still include this because it just summarizes really nicely a few things that I wanted to demonstrate, which is that we really have different gut microbiota and changes depending on certain diseases. So interestingly, some of the best data for pediatric intervention for using things like probiotics is in diarrheal diseases. So if you have traveler's diarrhea, antibiotic-induced diarrhea, if you're just a 2-year-old that has picked up some sort of bug, we do know that probiotics have been shown to be pretty effective in improving those conditions. However, and I think this is true even now in 2025, is that in conditions like inflammatory bowel disease, we know that baseline bacteria may have put people at risk for developing inflammatory bowel diseases, but it is very difficult to administer probiotics in any amount that is significant enough to treat something like IBD. And that could have something to do with the more transient nature of diarrheal illnesses versus sort of the long-term changes that are seen in inflammatory bowel diseases. And I'm not going to go over all of this slide, but my point in showing it is that in many different disease conditions that we see in pediatrics, we see changes in the gut microbiota, and specific bacteria are associated with greater risk for greater specific conditions. So whether that allows us to treat with synbiotics is still a bit up for debate, and what we'll be talking a little bit about in kidney disease today, but we do know that we see changes in our gut bacteria precipitating some of these diseases. And one really interesting discussion is whether we are putting our patients at risk or our children at risk for certain diseases earlier because of their gut microbiota. There's a lot of really interesting studies now saying that what happens in these early years in infancy and early childhood may set the stage for developing chronic diseases even as early as later childhood, that some of our older children and adolescents could potentially be have set the stage for kidney disease because of things that happened even earlier in childhood. So we do know that people, for example, who are at risk for autoimmune diseases, have a history of autoimmune issues in their family, we see that they may have genetic markers that precipitate diseases like FSGS or IgA nephropathy. And now we're understanding that it could be those genetics in combination with the microbiota, with a combination of other lifestyle factors, physical activity, etc. Of note, it is interesting that physical activity can also impact gut microbiota. And certainly, are we setting children up for chronic diseases into adulthood when they've had these risk factors at an early age? So now we're going to talk about the microbiota specifically in CKD. And one thing I wanted to mention on this slide is there is some interesting work in early CKD that inducing diarrhea actually slows the progression of CKD. So we're going to talk more about gut microbiota now, but I thought it interesting to mention that that even by means of getting rid of uremic toxins in the gut through means of diarrhea, which obviously is probably not sustainable, they have seen reductions in CKD progression, especially in many Asian countries. This is more of a common practice. So again, in this figure, we see the risk factors that I mentioned and dysbiosis and the positive things known to affect the gut and symbiosis in the gut. So let's dig in a little bit more to why the gut may be altered in CKD. Well, we know that as CKD progresses, we see a change in the composition of the gut microbiota. In certain kidney diseases, we may see increased oxalate and uric acid. This is also true of kidney stones. We see an altered epithelial barrier. So as CKD progresses, what we see is an accumulation of uremic toxins. We know that. And this also kind of goes into translocation. We see that indoxyl sulfate, that p-cresyl sulfate, different uremic toxins that accumulate in the gut. And as CKD progresses, we know that gut integrity is weakened. And so we're often seeing translocation from gut to blood and vice versa, which may cause increased progression of CKD. We see those changes in the gut barrier because of edema, because of inflammation, because of oxidative stress. Then we're counseling our patients to sometimes have decreased fruit and vegetable and fiber composition because we're worried about high potassium fruits and vegetables. And that's a whole separate webinar about whether we really need to be decreasing some of those fruits and vegetables, and if we can still manage to promote lower potassium fruits and vegetables. But again, that's a bigger topic. To limit phosphorus, we are often limiting yogurt and cheese consumption. And historically, I think we're starting to get away from this, but we were historically very concerned about protein and animal-based proteins, and we're promoting those, which may have been doing a disservice to the guts of our patients. There is research that phosphorus binders are known to alter the gut lumen. Oral iron is a possibility as well. And of course, our patients often use antibiotics. And then we've talked about sort of the neuroendocrine pathways and serotonin and some of the roles in that already, that many of our patients are struggling with depression and mood and lack of physical activity and all of those things. And this is just a really nice figure that I wanted to demonstrate. It just really nicely shows all the things that are going on with the body. And I won't go over this in detail, but look at all these issues with sodium homeostasis and blood pressure and, the role of hypertension and how that can change the gut, and decreased microbial short chain fatty acids and inflammation, and how it all leads to CKD progression. So certainly we are well aware that our gut plays a huge role in progression of CKD. Now we're going to talk specifically about the microbiome in pediatric CKD. And again, this is just a nice figure showing how things from childhood and our life cycle can really set the stage for risk for childhood CKD or adult CKD that may have started in childhood. So I wanted to start with this study because this was an important study done in 2016. Until that time, the gut in CKD had primarily been looked at in adults, and most of what we discussed was stuff we had extrapolated from adults to children. But the Midwest Pediatric Nephrology Consortium did a nice study looking at kids in 3 centers and really digging into the gut microbiota of pediatric patients with CKD. And specifically, the study looked at 39 patients on hemo-PD and transplant and compared them to 13 controls. They obtained stool samples from these patients and looked at the gut microbiota between these groups. And what they found was some actual data that we can use in pediatrics. So bacterial-derived uremic toxins were highest in hemo and PD compared to the controls and transplant patients. However, there was less bacterial diversity in PD patients and transplant patients compared to the healthy control. And a couple studies that I'm going to touch on later on discuss that not only does the gut microbiome seem to not get better during during transplant, it seems to actually continue to worsen, and we think that may be due to many of the medications that our patients take. PD patients have higher levels of certain bacteria like proteobacteria, and these are known to cause peritonitis episodes, where hemodialysis patients had different levels of undesirable bacteria. And that's just to say that, again, the gut is very diverse, and the things that affect the gut are different depending on what insults are going on with the gut and what's going on with the gut. So these ones found in hemodialysis are difficult to remove from the hemodialysis process because they're highly protein bound. And many of these are known to be bacteria that are very affected by translocation in the gut microbiome. So what can we do about this? Well, we do know that a balanced or high fiber or Mediterranean style diet is likely to help. I say Mediterranean diet a little tongue-in-cheek because we tend to say Mediterranean diet is a fix-all for everything. And the reality is that we know that there's many cultural patterns of eating that are appropriate, certain South American patterns, certain Asian or African or more Norwegian type eating patterns that are very beneficial in terms of fermented foods, high fiber foods. And so I don't think we have to say everybody has to strictly eat a Mediterranean diet. The point is really high fiber foods and fermented foods are what we want to include more of in the diet. The Mediterranean diet has just been the most well studied. Probiotic based foods or prebiotic foods that promote the development of short chain fatty acids in the guts, probiotics, synbiotics, postbiotics, that is really an emerging area that we don't know much about, whether we can directly, provide short chain fatty acids in the gut. Now, and forgive my fecal transplant is actually not an example of a postbiotic, but the idea of administration is comparable. There has been some limited data in using fecal transplants in children with kidney disease. There have been studies actually looking at a couple children who were on peritoneal dialysis that had recurrent C. difficile infections. And it showed that their gut microbiota improved. There's been some studies using it for the treatment of IgA nephropathy that showed improved kidney function and reduced proteinuria. So the studies in this area are really, really tentative. I will share, she didn't have CKD, but my own sister had recurrent C. difficile and eventually had a fecal transplant, and she has done so much better since she had that. She had a very bad case of C. diff from continued antibiotic use about 15 years ago that really messed up her gut. And she struggled with it until she had this fecal transplant. Archibose is actually a starchy compound that has been studied limitedly in patients with kidney disease, and it reduces some of those uremic toxins as well. So that's an area that we're studying that is not specifically described as like a probiotic or biotic, but is similar. And we do know that changes in diet, more of a Mediterranean style diet, has been shown to improve, for example, Crohn's patients. So I wanted to just show, this is a very small study, but the reason I'm showing it is because it is the only study of probiotic use in children that I have been able to find. Now, I've searched pretty significantly, but I may have missed something, so there may be another study, but as far as I know, this is the only one done in 2013 that they gave probiotics to 16 children receiving dialysis compared to 12 controls. They did show some reduction of these couple uremic toxins of these children that were on dialysis, and especially kids on PD had the highest levels. But unfortunately, the study did not show a significant enough improvement. So to summarize, they showed improvement, but not statistically significant improvement with the probiotic treatment. I think that unfortunately, the study has a lot of flaws. It was a very small number. It only lasted 12 weeks, and a lot of these other studies have been done for 6 months or more. There were some questions about dialysis adequacy in this population. So I would say that the study didn't show any improvement, but there was a lot of reasons that it may not have been successful. So this is just kind of an interesting thing that I thought was relevant to our discussion. I'm not trying to promote this product. I'm not even going to tell you the name of this probiotic product because I don't want to promote any commercial bias, but there, in a lot of the research I have done, has specific to kidney disease has been done by this company that developed an adult probiotic product. And I just think the discussion of how they developed it is very relevant to our discussion today. They started in the early 2000s with in vitro studies in flash showing that bacterial strains destroyed certain toxins. They moved it to like a simulated type dialysis environment. Then they moved to animals with rats and mini pigs. They would take 5-6 nephrectomized animals and give them probiotics, and found that they were able to reduce BUN levels and give them a greater, longer lifespan. They did some studies in zoo animals that had CKD that were going to die anyway if they didn't do anything. So they were given these probiotics and showed improvement in longevity in these vet studies and zoo studies. And then they finally moved to patients. Interestingly, this company shares that their first data on safety came from their 7 employees. Would make you a little nervous to work there, that you're going to be the test subject. But interestingly, what they showed in the development of this product is they needed a large number of colony forming units, or CFUs. They used 90 billion CFUs. A lot of over-the-counter products are maybe 6 billion CFUs. So they needed a large amount of CFUs to be able to make any impact on uremic toxins. So one of the best studies was at 5 institutions in 3 different countries. It was a 6-month prospective randomized double-blind controlled study that showed improvements in uremic toxins, including BUN, and slowing the progression of CKD significantly. And again, it's a commercial study. They're trying to promote their products, so take that with a grain of salt or take it with what you will. But they are not able to make claims because it is not a product that is they're able to register in drug trials, so they can only make structural functional claims. And in a webinar I listened to related to the development of this product, they had to spend millions to develop this product without the benefit of really being able to promote what it does because of the limitations from FDA. They did say that in a couple of customer satisfaction studies, 3/4 of their patients reported improved quality of life from the reduction of uremic toxins likely. And then they ended with a study that did some metabolic profiling showing that certain CKD patients may be more responsive to probiotics than others. So I thought that was interesting to share, just that probiotics may work for some of our CKD patients, but not all of them. And again, it depends on all these different genetic and lifestyle and other factors that may determine the changes in the gut, even beyond basic CKD. And of note, I think it's also important to mention that they did say if your patients are on vitamin K or warfarin, the probiotics could interact. So, like I said, I've been talking on this subject for quite a while. And when I first started, there were just a lot of individual studies. The last time, about 5 years ago, that I did this webinar, I think there was 3 meta-analysis, maybe no 5, that I reviewed, and I even put them side by side for comparison. With this search, 18 meta-analysis or systematic reviews on this topic just in the last 5, 6, 7 years. And so what I've done, because that would be a lot, is I looked for what I considered the best meta-analysis systematic reviews that especially were up to date. I looked for ones that were registered with Prospero or Cochrane that seemed to be the most comprehensive. And I wanted to share 3 of those with you. So Cooper in 2023 had the most studies, 45 studies with the largest number of patients. And this study looked at multiple laboratory markers, everything from these, uremic toxins to potassium and phosphorus, bicarbonate, etc. And what it really showed is in all these patients that were given probiotics, there were minimal and mild adverse events. Really, we're seeing things like just, maybe a little bit of indigestion or a little bit of initial diarrhea or some nausea. And most of these went away after a couple of weeks on the probiotic. What they found mostly is that things like BUN and uremic markers were improved, but other labs like creatinine weren't. The study by Liu in 2014, again, now the first study looked at lots of markers. These last two really just looked at renal function and things like the uremic markers and BUN and creatinine. And what both of these later studies showed was that you can improve the BUN, you can improve the uremic markers, but it is difficult to show improvement in creatinine clearance, or estimated GFR. And they think that it will be impossible to do a study that will ever show impact on that because there's so many variables in estimated GFR and creatinine clearance that are affected by race, age, all sorts of factors that are unique to the individual. So it would be hard to standardize a study. But these studies did show slowing of the progression of CKD, which I think is very important and very promising, and probably the most important takeaway from this research, that we have the potential to slow CKD. I will mention in these meta-analyses, there was one pediatric patient included in one of the studies by the Cooper Review. So again, very adult-based. So my summary: likely need to use for an extended period of time with greater amounts and diversity in CFUs. So again, kind of that take-home message from the company that developed the product. Probably most helpful in CKD pre-dialysis. They show that once you're on dialysis, it's hard to reverse that. You can improve uremic markers, but you can't slow CKD once you're already on dialysis. And as I mentioned, there's not going to be a lot of good answers on things like estimated GFR, but most of the studies universally showed that any side effects were mild and mostly GI discomforts. So I think it's hard to talk about probiotic studies or symbiotic studies without talking about fiber. Is fiber really the issue that we're looking at? So I think it's helpful to think about, is fiber enough? So again, there was about 8 studies, meta-analyses on fiber, and I picked out some. These were not actually as strong as the probiotic symbiotic studies, but some adult studies with fiber use showed the effect of dietary fiber supplements on uremic toxins, and found that yes, in fact, dietary fiber supplements can improve that, can improve uremic toxins. Another study in 2025 shows, again, reduction in uremic toxins and inflammatory markers, and that the supplementation was beneficial regardless of fiber type or stage of CKD. Now, this 2024 one looked at both fiber supplementation and high dietary fiber intake, and showed that dietary fiber intake reduced all-cause mortality as well as uremic toxins and the potential progression of CKD. So I think it's interesting that the one that included dietary fiber intake showed actual health benefits beyond the uremic toxins. And just a summary, fiber is a non-invasive intervention. We also know, I didn't include it here, but there's a whole clinical practice recommendation paper on fiber intake for children with CKD that has shown the benefits. So although we don't have a meta-analysis in fiber in children, we do have guidance on that. that shows the benefit of fiber intake in children. At a minimum, we're reducing uremic toxins at, potentially, especially with dietary fiber intake, we may even be reducing comorbidities, and supplements and dietary fiber are useful. Let's move to transplant, because honestly, this is where I get the most questions when people talk about fiber intake. So I'm not going to spend a lot of time on this next slide, but back in 2011, I attended the National Kidney Foundation, and there were 2 presentations on use of probiotics benefiting reduction of diarrhea and infection risk in transplant patients. And this research started with a bang, basically. It was very exciting. And I don't know what happened, but suddenly all the studies that they planned to publish seemed to go away. So I don't know what happened, if there was, a negative side effect or a concern from their institutional review board. But what it originally started out as a lot of promise in CKD and transplant specifically, kind of came to an abrupt stop. So what has happened since then? This is just kind of an overview, and I realize I'm short on time, so I'm going to pick up the pace. But we know that in transplant, patients are at risk for infections, and that our patients have altered gut microbiome. So not only may they likely go into transplant with a poor gut microbiome from uremic toxins, but the medications and the other issues related to transplant, the major surgery, that it doesn't improve and may actually get worse. We also know that when the gut microbiome isn't at a beneficial place, we actually need larger amounts of immunosuppressive meds to create the same effect, so that having a better gut microbiome may actually be able to reduce the nephrotoxic amounts of medicines that we have to take to maintain that transplant. This just shows in a study looking specifically at transplant patients, and this is up to 6 years out. So this is not immediately after transplant, but compared to healthy controls, transplant recipients have much reduced numbers of bacteria in their gut, reduced diversity of bacteria, which is not what we want. Again, this is just kind of a visual showing the negatives from transplant and the gut. We know that we still have leaky gut with translocation because we've compromised that gut in transplant, and that dysbiosis creates some regulatory T cell immune responses that affects immunity. Now, I pulled out just one Cochrane review. There were fewer, people are a little nervous about probiotics or synbiotics in transplant. So it makes sense that there were fewer meta-analyses, systematic reviews. So I pulled out 1 of 5, what I consider the best Cochrane review, with 250 recipients. There's lots of reasons to consider synbiotics. Most of these are done in liver recipients. And with liver patients, you have the added benefit of the potential modulation of ammonia, and they saw better outcomes with reduction in ammonia and improving that liver transplant outcome. There was one CKD study included in this, but at the time of this meta-analysis, they noted that there were 9 studies in progress at the time. And just to highlight one of them, I will note that a study that came out in 2023 did show improved uremic toxins in transplant recipients, which could reduce the progression of CKD in that transplanted kidney. So everybody wants to know what everybody else is doing. So I also wanted to highlight this study showing, it's a study again by the Midwest Nephrology Midwest Nephrology Consortium, Pediatric Nephrology Consortium. So they sent a survey to 64 pediatric nephrologists. And interestingly, that is a third of the active centers of pediatric transplant in the United States. And they went to Canada and one country in Africa as well. But 42% of nephrologists report that they use probiotics or synbiotics in their kidney transplant recipients, mainly for antibiotic-associated diarrhea or C. difficile. So I feel like this number is trending up. People are less afraid to use probiotics in this population. Doctors will report that they will hold in times of neutropenia or if a patient is using central line use because of reported safety concerns with those. 31% of the participants report that they do not use probiotics because of the lack of safety data. So basically, the data is mixed. More and more people are getting brave about using it in transplant recipients, and there is cause to. We can potentially reduce infection risk. We can potentially reduce the amount of immunosuppressive meds we have to use, potentially reduce antibiotic use. So briefly, I'm going to mention some other kidney conditions. There was some research in UTIs, a meta-analysis showing that you have about the same benefit using antibiotics or probiotics to prevent recurrent UTIs. The studies were poor, so they weren't able to make great conclusions, but it's interesting to think that they might be able to use probiotics instead of antibiotics to prevent UTIs, less antibiotic use. In AKI, this is kind of a newer area. What they've shown is that people with greater gut dysbiosis have greater severity of AKI. So whether that speaks to treatment during AKI, or if we just have to hope that patients who end up with AKI have a good gut going in, the best research actually is in kidney stones. There's a lot of studies showing that especially oxalate-based kidney stones, that gut microbiota that synthesize oxalate may be able to reduce the incidence of kidney stones. And there is some other areas with minimal research, case studies that I wanted to just mention that are up and coming, but there's not a lot of data yet. So this is really, I think, what many of you are wondering about, which is risks and harm. A study in pediatric patients, not CKD, but pediatric patients younger than 18 from 1995 to 2021 show that of negative impacts, there were 49 cases. There's no big studies. These are all case reports. That all 80% of these were from children younger than 2. 69% were sepsis related, and all had one or more conditions creating risk for invasive infections, such as using central lines, such as having already compromised gut integrity. Premature infants were by far the largest number of those who negative things have been reported in. Now, 3 children died of these 49 case reports. 2, it was thought that the probiotic bacteria-related infection was probably not the cause of death. It just may have caught, because there was an associated infection, that it exacerbated the problem. There's one, and it is a widely spread, widely known case of a 23-week premature infant that received a contaminated probiotic supplement, and it caused NEC, and the death was associated to that contaminated probiotic. So given that probiotics are used in children on a very, 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 very broad basis that we're not able to track, probably 49 case reports of negative outcomes over this many years indicates that it's probably minimal risk. And we have to think about anything we give our patients. We have negative side effects from medications all the time. We have case reports of negative outcomes from medications. So if we think of this in terms of that there can be negative outcomes from anything we give our patients, negative side effects, that might provide some perspective. I've included just a few examples here of negative case reports in the literature related to renal. A 60-year-old transplant patient who was nicked during an abdominal surgery, and they think that the probiotic that he was taking at the time then crossed that perforation in the gut and caused him to have sepsis. Some other examples, a patient with a lung infection who was an HIV positive lung transplant recipient, a type 1 diabetic older adult on CAPD, and as I mentioned, that widely publicized death from probiotic contaminated with mold that I mentioned before. So patients who are not just on dialysis, not just have a basic kidney transplant, but very, very complex patients are typically where our negative reports come from. I'll just briefly mention, and most of this is historic, but I have worked with patients who take yogurt or a basic probiotic, had benefit with yeast infections, reduction of diarrhea post-transplant. Another family that uses probiotics specifically when stools become loose and have beneficial results, yeast infections, and positive outcomes in transplant patients. So I have a bunch of reference slides and I'll let you look at those on your own, but my practical takeaways are synbiotics are becoming increasingly popular in adult CKD, but we really need more pediatric research. Fiber is likely beneficial with minimal harm in other healthy fermented foods. I feel like the most promise is in CKD pre-dialysis to slow the progression of CKD. And I would say, especially for those nervous with transplant patients, if you're going to use them in transplant patients, work with your pharmacist, work with your team, work with your doctor, so that you can use products that perhaps have undergone independent inspection. Companies will pay to have outside vendors look for safety. So some things to think about in the take-home message. And I'll just leave you with the quote that especially food is and fermented and high fiber foods is probably our best consideration when it comes to this topic. I apologize. I get way too excited when I talk about this. I intended to leave a lot more time for questions, and I am happy to stay on, after the hour, but I am happy to take questions now.
Christina, that was amazing. Thank you so much. We do have some questions. So the first one is long, so stay with me. This is from Anonymous. Did the studies looking at fiber intake in dialysis patients identify if benefits were seen with insoluble or soluble fiber? Most of my patients, oh, sorry.
Go ahead.
Let me give you the whole. Most of my patients struggle to keep their phosphorus within normal limits, and whole grains tend to have more phos than white bread and rice. Will switching to whole grains provide more benefits than risks? So we got a lot in there. I can repeat it.
Yes. No, that's an excellent question. So, and I briefly, I know I had too much data. I know I had too much information in this talk because it's such a broad topic and I find it really interesting. But those 3 meta-analysis that I showed you really demonstrates that it doesn't matter if it's insoluble or soluble, and oral dietary fiber intake in the meta-analysis showed actual outcome improvement in adults with things like cardiovascular disease. All the meta-analyses showed that whether it's supplemental, so giving a fiber supplement, or oral intake, showed improvement in the uremic toxins. And I didn't have time to talk about this, but in the CPR and the research in children related to fiber, it also indicates the clinical practice recommendations say that supplements are also beneficial, that we promote oral dietary fiber first, but supplements are a good second option, and that both types of fiber are beneficial. I am a huge proponent of encouraging whole grains in our CKD and dialysis patients. Research shows that even though on paper in the nutrient databases, they're higher in phosphorus, that phosphorus is much less bioavailable. And so we're getting probably realistically about the same amount of phosphorus, whether we give white bread or whole grain bread, because of that bioavailability. It's difficult to prove that, but from what I've read, we're probably about equal, and you're getting the benefit of the fiber when you give the whole grain products. So I'm all for giving beans, nuts, whole grains, fibrous vegetables to our dialysis patients, because we just know that the bioavailability of the phosphorus in those high fiber foods is so much less than the nutrient databases show us on paper.
Thank you. I think that helped someone else's question too.
Oh, great.
If I'm wrong about that, please just ask again. Anonymous would like to know which probiotic strains would you recommend they try to include for pediatric post-renal transplant patients?
It's a good question. So the bifidobacterias are shown to have a lot of benefit, especially in pediatric patients. Lactobacillus strains, now interestingly, the most infections have been shown with those lactobacillus strains. Those case reports primarily are from lactobacillus strains. But they also have the most promise. You know, lactobacillus strains are what we see in breast milk, and the positive benefits of that we see in developing that gut microbiome. So I think that as long as you're working with your physician and your pharmacist and the people on your team to making sure that you're picking a product that has some good safety, independent studies behind it, or independent evaluation, lactobacillus can be beneficial. The importance is diversity, because your gut microbiome depends on what's happened to you through your life, your race, your gender, your age. We're never going to find, unless we did extensive microbiomic studies on each person, it's going to be difficult to find the exact right magic bullet for every patient. So what we do know is that a diversity of strains is probably our best bet to be able to add diversity and quantity to our gut, which is really what we're looking to do from a protective effect.
So fascinating. I heard you loud and clear with the diversity. Sarah is asking, what are the best strains of probiotics for dialysis patients? So given the rationale, diversity, we want to seek that. Are there a couple that rise to the top of your list?
Boy, you know what? I am happy to research this question further and get back to you. I cannot remember the names off the top of my head. That company, and I really don't want to promote brand specific, but that company that developed that probiotic strain specifically for dialysis patients put a lot of research into the best types of bacteria that went into their strain. And I know there was some lactobacillus, I know there was some bifidobacteria, but I cannot remember for the life of me the other about 5 main strains that they put in their product. That was, and really the best research, even though it's commercially biased, kind of went into their research looking at the types of bacteria that were lacking in those patients. And actually, I'm going to go back to, you know what, I throw my notes on the floor as I read, as I review things. So they're in a mess and a pile on my floor, but I did have some specific names of types of bacteria. I'm going to see if I can go back to those slides.
Yeah, thank you. Yeah, these names are something else.
Name specific. Yeah, these names are kind of tricky and I don't have them all memorized. I'm going to be frank about that. So feel free to go ahead while I look for the names if they're on my slides, and if I have to, I'm going to go back to the.
Okay.
Oh, here we go. So the 2028 study in specific in transplant, they use these strains specific for transplant and had really good success with them.
Oh, great. Thank you.
Yeah,
awesome.
And I'm going to go back to my CKD slides and see if I can find them. But feel free to ask another question, Michelle.
Okay. So this is from Susan. Could you speak about fermented foods and how they could fit into a renal diet?
Sure. So kefir is certainly an option. And I know many kefirs are milk-based, but they also have water-based kefirs. I make my own kefir and I'm a fan of that, but I also don't have kidney disease. I do have a suppressed immune system, but that's another story. I feel safe doing that, but when we're working with patients, I think that we do potentially run into concerns about safety if people are making their own kefir. So I would promote for our patients just to err on the side of safety, that we probably want to produce, or we probably want to promote store-bought, because it's undergone food safety recommendations with our patients in terms of kefir. Unfortunately, I think I just talk about the negative strains of bacteria on these slides, so my apologies, but I can send an email with some of the names of those bacteria specifically.
Yeah, that's awesome. We can
send
it out to everyone. Yeah,
yeah.
We can send an email.
Yeah, but what was the question again? I lost my train of thought.
Well, we'll keep going. So this was about some of the best strains for dialysis, but Laura, hey Laura, nice to see you. Just wanted to share there is a renal product that includes Streptococcus thermophilus, Lactobacillus acidophilus, and Bifidobacterium longum. So I just thought that was interesting, and thank you for the feedback.
Yeah, thanks for sharing that.
Here's a question from Lucy. Should probiotics, prebiotics be added to enteral nutrition supplements for pediatric CKD? She'd love your opinion.
Well, if you guys can't tell, I tend to be on the probiotic side with the caveats that I think that if we can do it with food, that's always going to be our best bet, high fiber foods. And that we have to be absolutely vigilant on safety. So we, of course, have many patients that can't have food for whatever reason, or who are on enteral feeds. And I think that, there are several pediatric enteral formulas out there for the general population that include some beneficial bacteria. There's products out there. My personal opinion is I would make a formulation with and one without, because I think for those, what I'm seeing, the trend in renal now is that we are seeing more and more complex patients. We are seeing kids with, multiple complications, NICU grads that even 10 years ago probably wouldn't have survived. And these kids are surviving, and as a side effect of their complex medical situations, they're needing dialysis or having CKD. So for those kids that have multiple comorbidities, and unfortunately, those may be the patients that might benefit most, but given the safety risks with the most medically complex patients, I would still maintain a formulation that maybe doesn't have that option. But I think especially for our CKD population, kill two birds with one stone, it would be a great option to see some products, because we know that some of these products are being used and working well. And there's a trend in real food products that promote prebiotic type materials. Another thing with many of our renal products, you mix them with another formula to create a custom product. So potentially mixing a renal formula with a plant-based or real food alternative could be an option. So I'll just say I think options are good.
Okay, Christina, I'm going to take one more question. I just want to remind everyone, you do need to fill out the knowledge assessment. It's just a couple questions, and then you'll be able to download your CPE certificate. So you'll see CPE certificate on the left, and that will allow you to do that. This last question is from Hector. Hector, hello. It's so nice to see you. This kind of tail ends from what you were just talking about, Christina. So Hector's question is, can you give your thoughts on using probiotics for infants and young children on peritoneal dialysis? I've got a provider who typically says no due to concern of peritonitis. I'd love to hear your thoughts on this. Thank you.
So I think, again, one of our best opportunities is probably in peritonitis. I would say the best evidence is, of course, in pre-dialysis CKD, but our PD patients are at the most risk for infections, and there's lots of evidence that says that PD patients have specific types of negative gut microbiota that can contribute to peritonitis. So I would say that could be a big opportunity, even more than hemo, because we are dealing with the peritoneum and the organs and the gut so much more even than hemodialysis. So as long as you're working with your team, ideally a pharmacist, to get a vetted strain. Now, again, there was that case report of that CAPD patient who had type 1 diabetes, who was an older person. So you have to be careful, but an otherwise fairly healthy child on PD, I personally think it could be worth a try. And not only that, but there have been no deaths reported in dialysis patients associated with probiotics. All those case reports that I shared that, and I have combed the literature pretty extensively for CKD related negative outcomes, and nobody was on dialysis that had a very serious outcome. So I'm not to say that we want patients to, have any negative outcomes, but could the risks potentially outweigh the negatives? I think the potential for reducing the risk of peritonitis, especially if you have a patient with recurrent peritonitis, could be well worth it.
Fascinating. Thank you. So I just want to say thank you again to Christina. Thank you to our audience today for your participation. We hope you enjoyed the presentation and found the information helpful to your practice. If you enjoyed spending time with us, I just want to let you know that October 15th to the 17th, we are having our Advanced Pediatric Renal Nutrition Academy. This is the 15th, so this is the advanced program. There is no charge to attend. We do record it. We do hold it through this platform, SpotMe, and we do offer quite a few continuing professional education units for US dietitians. So please feel free to email me. I'm pretty sure everyone has my email address if you would like more information. It was wonderful seeing you all remotely, and I hope you have a great day.